I'm going to say a little bit about the anatomy of this all. The amygdala, which is this little bit here, is the sentry, which alerts the adrenals to stress and enhances the acquisition of traumatic memories. And traumatic memories are different from ordinary memories, as we shall see. The amygdala seems to respond to severe traumas with an unerasable fear response, which sticks in the mind. It seems to be genetically different and wired for a higher level of fear in some individuals. Not everybody, but seems to be enormous individual variation in the vulnerability to PTSD. But this acquisition of unerasable fear responses seems to be at the root of PTSD. Now, hippocampus, which as you can see is very close to the amygdala, is the organ responsible for new learning. And contrary to what's previously believed, as I said just now, the brain can generate new neurons, which is called neurogenesis. And the hippocampus, being a high turnover, i.e. an area where brain cells are being born and dying quite frequently, is the active site of constant neurogenesis. In PTSD, excessive glucocorticoid activity inhibits hippocampal neurogenesis and causes atrophy and cell death and dysfunction. It leads to the storage of memories that lack what's called a spatio-temporal framework, and this is the characteristic of flashbacks. You remember in PTSD, people keep getting these, they're reliving the event as if it were happening all over again. A woman will be sitting in her chair, and on the television, a blank television screen, she sees the face of her dead child, or she sees her husband dying as it was like a film strip that's playing itself. So just to remind you of the diagnostic criteria for PTSD, an event evoking intense fear, helplessness, or horror, associating, giving rise to these vivid, intrusive memories or imagery. I say imagery because they don't have to be memories. For example, a mother who's lost a child in a car smash may not have actually seen the car smash, but she has a vivid mental picture of it in her mind as if she had witnessed it. And she may find herself reliving that memory, that imagery, as if it were a memory. And many people manage to avoid their memories during the daytime, but they come back in the form of recurrent nightmares. So characteristic nightmares, example of which I'll give you in a minute. These memories are so painful and they're triggered off so easily that people go to great lengths to avoid anything which will trigger them off, the events that will remind them of their loss. They may shut themselves up at home for fear that if they go out, they'll meet people in the street who will say, "I'm so sorry to hear about your child." Bring it all back over again. Or they may hear a police siren, or a gunshot, or marching feet, or whatever it is that triggers the memory. And this avoidance may be quite paralyzing because people are unable to go back to work, and there may be their ability to function in a satisfactory and happy way is seriously impaired. Despite all this avoidance, they remain hyper-alert, physiologically aroused with the kinds of symptoms we talked about just now as symptoms of anxiety. If that continues for more than 2 months, it falls within the diagnostic category for the DSM diagnosis of PTSD. And as you can guess, in disaster situations and traumatic bereavements, there are many people who don't actually meet all those criteria, but who nevertheless have some of the features that I've talked about. It's hard to grieve when you're constantly trying to avoid thoughts of the death or the dead person. So it's almost necessary to treat the PTSD before you can help people with their bereavement. By the same token, one shouldn't assume that just because someone's now been successfully treated for bereavement, for PTSD, that they won't have any problems with their bereavement. They may still find difficulties in grieving. It's not surprising, therefore, that PTSD may be associated with delayed or avoided grief. And this may explain why avoided griefs and delayed griefs are much commoner following traumatic types of bereavement. So we need to treat the PTSD. What helps? Well, for minor forms, supportive counselling, just helping people to feel safe enough to think and talk about the traumatic event, the things that make them feel very unsafe, will often be sufficient to put them back feeling at least empowered, with a feeling that, yeah, I can cope with this, I can live with these memories. Cognitive behaviour therapy, which I'm not skilled in, has produced good results in some cases, but the treatment that has best stood the test of random assignment is no doubt EMDR, eye movement desensitization and reprocessing, which was discovered quite by accident, which seems very weird. Again, I don't have time to teach you EMDR, but basically it's a way of helping people to live with their memories and to gradually diminish the power of the memory. What the psychologists do, who specialize in this, is to, first of all, discuss with the patient or client what are the things you find most distressing, producing a sort of checklist with scores of 1 to 10 on the amount of distress which you experience when you remember such and such. And they then choose the most serious, the most severe and distressing memory. They say, okay, I want you to hold that in your mind while watching my finger or my watch or whatever, some object going back and forth, 20 oscillations to and fro, as you watch that movement. What the movement seems to do is to anchor the person's attention. You know, it's possible to think of 2 things at the same time. It's not possible to think of 3 things at the same time. So in a way, by giving the person something to watch while they're thinking the traumatic memory, it helps to stop them from being distracted, perhaps. There's a lot of theories about why this works, but it does. And what you find is after going through, say, 20 oscillations, you stop. And at this point, the person's invited to rescore the intensity of their distress, following which it's usually dropped a few points. You then repeat the exercise until you've got it down from maybe 10 to 5. At that point, you leave it for another week. The surprising thing is a week later, they still are only scoring 5 or 6 on that memory. It doesn't go back to the 10 level again. And repeating the exercise several times, you eventually get it down to a tolerable level, 2 or 3 maybe. You're never going to completely extinguish it. And the aim is not to help people to forget. It's to help people to live with the memory without being so overwhelmed by the distress that they can't function.